Ladies and gentlemen, thank you for your patience in holding. We now have your speakers in conference. Please be aware that each of your lines is in a listen-only mode. I will now turn the conference over to Lisa Araspacachaga. Ma'am, you may begin.
Thank you so much. And thank you to all of you for joining us for today's webinar, When a Radiologist Becomes the Patient, Radiologists as Hospital Change Agents, brought to you by the AHA's Physician Leadership Forum in partnership with the American College of Radiology. And I'm really pleased to have with us today a very strong team of Dr. Sabiha Raoof, Chair of Radiology and Chief Medical Officer at Jamaica and Flushing Hospitals, and Bruce Flanz, Chief Executive Officer of Medicis Health Network. We also have with us Amy Kotsenas, Dr. Amy Kotsenas, Associate Professor of Radiology at Mayo Clinic Rochester, who will be moderating today's session. Before we get started, I do want to ask a few quick questions just to understand who's on the line with us and give our presenters a little bit of a sense of who's with us. So we have a couple of quick polling questions. The first one is just to get some sense of the size of your organization, where you're located, and your role in the organization, just so we have a quick sense of who's on the line. Looks like a lot of pretty large hospitals in urban settings and a lot of hospital administrators so far. We'll give it a few more seconds to get a sense. All right, it looks like we are largely at larger urban hospitals, some clinicians and hospital administrators on the line. Well, thank you so much. We really appreciate you giving us a sense of who's on the line. And with that, I'm going to turn it over to Bruce Flanz to give you a bit of an update, bit of a sense of their organization, and let them take it from there.
Well, thank you very much. I'd like to provide a context for today's session. So in front of you, you have a map of the hospital delivery system in Queens as it looks like today in 2017. Looks quite different than it did a decade ago in 2007 when we had 15 hospitals. Today we only have 9 hospitals. We lost 1 level 1 trauma center, 4 acute care hospitals, and 1 psychiatric hospital. Moving to the next slide, just a little bit about Queens County. Queens County is often called the world's borough. It is the most culturally diverse of the 3,000 counties in the United States. There's a population of more than 2.3 million people who live in Queens. Almost 50% of the population was born outside of the country, and it's estimated that about 250,000 are undocumented individuals, and it's also estimated that about 15 to 25% of the county's residents are uninsured. Our population comes from over 120 different countries, and they speak over 135 different languages. There are multiple ethnic neighborhoods. For example, the community around one of our hospitals, Jamaica Hospital, is Richmond Hill, which is known as Little Guyana because it is the largest concentration of Guyanese individuals living outside of Guyana. There are approximately 50,000 individuals of Guyanese descent. Jamaica Hospital is also the closest hospital and level 1 trauma center to JFK Airport, and serves as the backup facility, backup healthcare facility for the country's busiest airport. And this week and next week, just as an example, we serve an especially important role in that every one of the world leaders that will be attending the United Nations General Assembly will be flying into JFK and passing by our organization.
And really the strength of our organization lies in our ability to deliver culturally competent services, and the diversity of our staff is reflective of the diversity of the patient population that we serve. We all know that a lack of diversity in healthcare workers can be a major barrier to cultural competence. Like Bruce said, we have about 135 spoken languages in Queens County, and our own staff speaks over 100 languages.
And if we could move to the next slide. This is another map of Queens, but it is a map of the Medicis Health Network delivery system. Before going into the details of what you're seeing in front of you, I'd like to share with you that we are transforming our organization from quantity to quality, from inpatient to outpatient, from fee-for-service to value-based payments, and from physician-focused care to patient and family-centered engaged care. What you see in front of you shows our 2 hospitals, 1 nursing home, 9 ambulatory care centers, 15 physician practice offices, and 3 behavioral health centers. And it's interesting to note that we have integrated physical health into our behavioral health centers, and we have integrated behavioral health into our ambulatory care centers. And as you can see from this slide, nearly half of all of our revenues come from value-based payment arrangements where we take full capitated risk on over 133,000 lives. If you move to the next slide, this will further demonstrate that we're a safety net provider. If you look at our payer mix, 60% is Medicaid, 20% Medicare, 5% is self-pay, we should also call that no pay, and 15% is commercially insured. The Hospital Association of New York State has done an analysis of payer mix of all the health systems in New York State, and Medicis Health Network has been determined to have the highest percentage of government pay of all of the systems in New York State.
Thank you, Bruce and Sabiha, for that background on your system. I'd like to ask the audience at this point in time to take a moment to think about their own system and their own institution and how it compares to Bruce and Sabiha's. Is yours bigger? Is it smaller? How are you handling value-based payment models? We'll spend the rest of the time on this webinar talking about 3 key concepts: engagement, alignment, and empowerment. And I'd like to say at this point that I think the numbers that you shared don't really tell the whole story. So I would like Sabiha to tell us about her patient experience and how it prompted her to accelerate the pace of patient family-centered care at your institution.
Thank you, Amy. Well, I'm very fortunate to be part of this organization for the last 20 years. I came here as a young attending right out of fellowship. The job market at that time was very tight in radiology, and I took this job as an interim. I wanted to look for a job closer to home, but very quickly I realized that I wanted to stay here and continue to serve this patient population. I ended up moving my home, not my job. A few years later, I was offered the opportunity to become the chair of radiology. I took it as a challenge, so I worked very hard to build a quality department. I hired board-certified and fellowship-trained radiologists. I got the entire department ACR accredited. I then took over the radiology department in our sister hospital, which is Flushing Hospital, and built that department up. But what I did not really realize at that time was that my biggest challenge was yet to come. So at age 40, I did my first mammogram, and I diagnosed my own breast cancer. As a mammographer, I had seen hundreds of breast cancer patients, but this experience was different. During my treatment, I got to see healthcare delivery process from the other side of the fence. Very quickly, I realized how difficult it is for patients to navigate the system. It is because of these experiences that I realized I really needed to do something more to improve the patient experience in my hospital. As a radiologist, you all know that we don't have the opportunity to interact much with patients. So I approached Bruce and I requested him if he would allow me to round on inpatient units on behalf of our administration. My aim was to speak with patients about their overall experiences and help them with issues that bothered them. He agreed for me to round, so I started my rounding on inpatient units. I rounded a couple of hours every week. I spoke to the patients about their care. And most of these issues that they complained about were small things like an extra blanket, the food was cold, can I have a different entree for lunch? I could relate to these issues because I had been there not too long ago. I knew that as a patient, these seemingly small annoyances are a big deal. So I listened and I tried to solve these issues right away. I could actually do service recovery while the patient was still in the hospital. So after a few weeks, Bruce happened to mention this at a hospital-wide meeting. Right after that meeting, 3 other non-clinical managerial staff members got interested and they told me that they would like to do this project with me. So together we designed the Make a Difference rounds, or the MAD rounds as we call them. We plan to have all clinical, nursing, and administrative leadership in our hospital join us. So we came up with a list of about 100 members, and we presented our plan first to senior leadership and then to this group of leaders that we had selected. We started MAD rounds with teams of 3 going out to patient units every day. We spoke to our patients and we tried to solve their issues in real time. In the initial design, we really did not capture data because our goal was simply to allow for maximum patient engagement each and every day. After having the program running for 2.5 years, we decided to redesign the structure of the MAD round teams. And this was based on the input from our participants. Our physician members found that it was difficult to coordinate their rounding times with 2 other non-clinical members, and the members needed more flexibility. We also at this point said that it's about time that we start collecting data on these rounds. So in the new structure now, we have about 5 to 6 members per team assigned to a floor for 1 month. And 1 member of the team goes out every day and makes the rounds. There's a team leader who then coordinates the schedules and facilitates communication between the members. We also met with our IT department and expressed our interest in collecting data. They helped design a rounding app for our phones and computers, so now we can enter data on our mobile devices and on our personal computers. We have also become an integral part of our patient experience committee, and the reports and the data that we collect, we share at that forum. There's another very important program that came out of this project. It's called the I Listen program. An area of concern that was picked up during these rounds was communication skills, especially with our residents. So many of our physician leaders got together and we felt that there was a need to improve their interactive skills. Our program director of family medicine took the lead and she developed the I Listen program to train the residents to communicate more effectively. She really has done a great job and the residents receive this training on an ongoing basis. The MAD rounds has also given our staff, both the clinicians and the non-clinicians on the team, a chance to understand the issues our patients encounter. We can engage our patients in a way that demonstrates that we care and we can display our commitment to providing the highest quality care. At the same time, we have the opportunity to engage our staff while we are on the patient floors. We are able to discuss patient issues with the frontline staff, and we are also able to share the positive feedback that many of our patients provide. After the MAD rounds initiative, I started focusing on improving the patient experience in my own radiology departments. We used American College of Radiology's Imaging 3.0 roadmap to transform our processes and to provide patient-focused high-quality care. So today in my department, every single member is focused on improving patient experience from the time the study is scheduled, registration is done, the study is performed, the study is dictated, and the report is sent to the physician. We have developed metrics to improve quality of care at each and every step of the imaging value chain. We also wanted to find out how our patients are experiencing when they are in the department. So we have electronic, actually a survey going out on their mobile devices. It's called Rate My Hospital. We ask the patient's permission if it's okay with them to send the survey to their mobile devices. our response has been great, and they respond within 40 to 45 minutes, and currently our ratings are 4.5, 4.8 out of 5. American College of Radiology provides great resources for the radiologists and for the CEOs who want to look at various steps in their workflow and find opportunities to add value. So at this point, I would want to turn it over to Amy so she can give us a brief overview of the Imaging 3.0.
Thank you, Sabiha. I'm glad that you mentioned the ACR's Imaging 3.0. It really is radiology's roadmap as we go from volume to value. And I wanted to share with the audience, since many of the audience members are not radiologists, what exactly we mean by Imaging 3.0. We all know that modern healthcare delivery is about coordinated teams that are efficient and effective. And in radiology, we think that imaging really has a huge role to play on these healthcare teams. So what is Imaging 3.0? It's both our vision and our game plan, not just for radiologists, but for everyone in healthcare, radiologists, policymakers, payers, referring physicians, and I think, as you mentioned, Sabiha, it's especially important for our patients. The goal that we have is really to provide optimal imaging care from the moment a clinician considers ordering an imaging study or an imaging-based treatment until that referring physician receives and understands an actionable report with evidence-based recommendations. Put simply, Imaging 3.0 is about ensuring that our healthcare systems squeeze every possible ounce of value out of imaging to help our patients and the transformation of the healthcare system. ACR's Imaging 3.0 focuses on 3 pillars: appropriateness, quality, safety, efficiency, and satisfaction. It's about delivering all of the imaging care that is beneficial and necessary to our patients, but none that is not. And it's really the way that radiologists are rapidly moving from a volume-based payment system to a value-based payment system. For healthcare transformation to succeed, we believe that Imaging 3.0 has to succeed. And we're getting there by doing 3 key things. First, we're changing the culture in radiology and within the entire healthcare system. We're more tightly integrating radiologists and the knowledge that radiologists bring to the table into the healthcare delivery system. Second, we're rolling out tools like clinical decision support for imaging, actionable radiology reports with multimedia content, image exchange, and patient data registries. And then finally, we're changing the policy conversation in Washington, and we're seeing some early successes in realigning the incentives to move radiology from being driven by volume to being driven by value. So what does a change to Imaging 3.0 feel like to radiologists and the referring physicians and patients? Well, it's really a completely different mindset from the one that we've been used to in the past. For ACR members, we hear that they're feeling empowered to be doctors again. We're seeing a number of changes in the Imaging 3.0 era. We're moving from a volume-based to a value-based payment model. We're seeing a return from transactional relationships to consultative relationships with other healthcare providers. We've moved from a radiologist-centric model to one that's a patient-centric model. We're moving from an interpretation-focused process to one that's much more focused on patient outcomes. As a result, we're seeing radiologists move from feeling commoditized to feeling integral to patient care. And radiologists are moving from being invisible care providers to accountable healthcare providers and really key members and leaders of the healthcare delivery team. And I think that you've exemplified that, Sabiha, with your MAD round. I did want to ask Bruce if he could dig in a little bit more details into the organizational priorities to describe the basis for the work that you're both doing together.
Oh, thank you, Amy. It'd be my pleasure, and we can move to the next slide. So everyone in our organization knows that it's a pretty simple formula: high quality and low cost equals value. And it's absolutely imperative the quality and patient safety always comes first. So as an example, I mentioned earlier that we've jumped into value-based payments with both feet having 133,000 fully capitated lives through a managed care company that we have an ownership interest in. In that managed care organization, there are about 40 hospitals that participate. I'm proud to tell you that of the 40 hospitals, Flushing Hospital ranks number 1 in terms of quality, and Jamaica Hospital ranks number 3 in terms of quality. Other indicators of quality are our focus on hospital-acquired conditions. For example, I'll use one of the things we focus on with hospital-acquired infections, our laser focus on reducing CLABSIs to 0. In the neonatal intensive care unit, we have not had an infection for the last 4 years, and in the surgical intensive care unit, we've not had a CLABSI infection in the last 3 years. Another example would be our success with regard to pressure injuries, where we have not had a pressure injury in the last 20 months in our critical care units, and now we're expanding those same strategies onto the medical surgical floors. One of the things that we've learned is that credibility is critical.
And I do want to stress the credibility part, because Bruce's mantra at every meeting is quality patient safety, but it holds value only when he walks the talk. So when Bruce is present at every single infection control meeting, at every single PI meeting and safety huddle every morning, not in 1 but in 2 hospitals, it leaves no choice for the rest of us to be involved in that process improvement and improving the quality and safety of our patients, for our patients.
So that's what we refer to as leading by example, and I'll come back to that in just a moment. But as we move to the next slide, I'd like to go on with our organizational priorities. We've learned that every organization has its assets, and our greatest asset is our workforce. So we take pride in trying to help maintain the wellness of our staff and of our physicians, and that's why we've created these priorities for the people who work here. And it always has to be in this order. It always has to be your health, your family, your job. You need to be healthy in order for you to be good to your family and good at work, and you need to be happy in your personal life in order for you to be fully productive in your professional life. So it always has to be this order: your health, your family, your job.
And I can vouch for that, because having been in this organization for the last 20 years, I really see this happen. So when I was diagnosed with cancer and I went through my cancer treatment, the support that I got from my administration was unbelievable. Again, they provided that flexibility that I needed during that difficult period of my life. I also want to emphasize family. It is great to know that our senior leadership respects our responsibilities at home, and flexibility really matters. Personally, it has allowed me to juggle my career advancement with family obligations and needs. Maybe it was a little easier in radiology, but today when I'm in that leadership role where I can provide similar flexibility to my physicians, it has helped me retain my staff, and I believe they appreciate it. We have also recently had discussions in other departments. We sat with our primary care physicians to see how we can come up with flexible options for our physicians so we can cater to their needs. And we hope that we'll have better retention and hope to improve hiring opportunities in those areas. A very recent example, we have a young female physician who's really interested in performance improvement, and we appointed her as the chair of our PI committee. So we had a meeting last week on Thursday, and on Wednesday, Bruce gives me a call and tells me, are the New York City schools opening on Thursday? I said, yes, but why are you asking? And he told me, well, I know that Susan is going to be coming to the meeting and not going with her daughter to first day of school, so you better call her and tell her that she needs to go to the school, and we'll take care of the meeting. it was just unbelievable for me to hear that. And when we called Susan, her response was, "This is why I love working here." So it really has been a pleasure to be a part of this organization.
So as we continue with the next slide, talking about transformational change at a safety net hospital, every organization has its assets. As a safety net hospital, we've always been challenged financially, but as I said a little bit earlier, our greatest asset has always been our human resources, our workforce, and that's why we encourage people to achieve their fullest potential. And you heard about Sabiha, her involvement with the American College of Radiology. She's also the ACR representative to CMS in their TCPI, Transforming Clinical Practices Initiatives. She serves as a national faculty member, and that's why it was easy for us to not only recognize her as our chairperson of radiology, but then to promote her to also be our Chief Medical Officer. I should mention that Sabiha and her team has also recently been given the distinction of achieving the Digital Imaging Center of Excellence. So we're very proud of her and her team for that accomplishment. I want to just expand a little bit on what I said earlier about leading by example. As a leader, you have to be secure in yourself. So you need to surround yourself with the best people possible, and then you have to be willing to delegate to them, because it doesn't necessarily take your involvement in order to accomplish the goals. And we certainly are fortunate in that regard to have Sabiha and so many other wonderful professionals on our team. The next slide, if we could, Amy.
Did you have a question, Amy?
I was just going to ask. I was going to ask Bruce. We hear the word empowerment a lot. It's a buzzword at many institutions, and I wanted him to describe a little bit more about what it means at your hospital.
Sure. Thank you, and I'll be happy to try to answer that. So, with very little resources, we try to just do what we know is the right thing to do. Some people call it rapid process improvement. I'd like to give you a couple examples of that. So we implemented about 2.5 years ago safety huddles on both campuses at 10 o'clock in the morning, where leadership participates in a very important communication that takes 10 to 15 minutes, and we learn so much about what's going on in the organization. What's really important about the safety huddle is how quickly we implemented it. We learned about safety huddles, and within 3 weeks we implemented the safety huddles, and then 2 weeks after implementing them, we expanded them from 5 days a week to 7-day-a-week huddles. Another example of rapid process improvement in our organization is the implementation of our electronic medical record. So on August 1st, 2011, we implemented the EPIC electronic medical record, and I'd like to just expand on that for a second. On July 31st, 2011, we had paper, and then on August 1st, 2011, the very next day, we had no paper. We went big bang, 17 applications across every aspect of our organization, and we did this with after only 12 months of training. So we think that is just another indicator of rapid process improvement.
And really, Amy, we really feel empowered if we think there's a idea that we want to test and any project we want to start. We are given that opportunity and to run with that idea and do something about it. And Matt Rounce is an example of that. I know another radiologist who got interested when he heard about my project, and in his hospital, he tried for 2 years to get it through the committees, and at end of 2 years was told he can't do it. Here in our organization, we don't have the luxury to run ideas through different committees. We just come up with the idea, we run with it. It works great. If it doesn't work, we stop, we redesign, we reevaluate, and that's how we do it.
So I think that's a really interesting contrast with my organization. I work at Mayo Clinic, and we certainly have a lot of experience with innovation and process improvement, but I would say that it takes us much longer to get things done. We have a committee structure that most things do have to go through. Bruce mentioned your experience rolling out an EHR system. We're in the process of doing the same thing at Mayo Clinic, and our project is planned to be a 4-year timeline. So I think it's really inspiring to see the number of things that you're able to do in a much smaller organization.
Well, thank you for that. A lot of what we're describing is an outgrowth of our guiding principles, which I think might be on the next slide. Vision, teamwork, and commitment. Vision is knowing where you want to get to. No matter how bleak things seem today, you always have to have a plan for the future, because otherwise the future is going to pass us by. And the way that we get things done is with teamwork. It's not 1 or 2 or 3 people. It's not just me and Sabiha and our other leadership people, but it's all 6,000 people in our organization working together to make sure that we accomplish the goals. And commitment, no one is more committed to achieving these goals than all of the members of our team. So please consider those important guiding principles: vision, teamwork, and commitment.
So Bruce, I'm thinking how these principles, vision, teamwork, and commitment, fit really well with the principles that I described about Imaging 3.0 and patient and family-centered care. Could you talk a little bit more, about how the MAD rounds fits in with that alignment that I talked about and patient and family-centered care?
Well, we've made patient and family-centered care a priority. We put together a patient experience committee that I co-chair with our chief nursing officer. We have patients, both current patients and former patients, come and talk to us about their experiences, both what was positive about their experience and also those areas where we could improve on their experience. So we learned from that. We've learned a tremendous amount from the MAD rounds, and I think Sabiha is even better positioned to share her thoughts on that.
No, with the MAD rounds, it has really brought a big group of people together who have clinical backgrounds and who don't have clinical backgrounds. And going through this experience with the MAD rounds has really helped them understand what the patient feels in the hospital. So, for example, one of the members of our team, MAD team, is somebody from purchasing and another person from finance. I mean, they didn't understand when we went to them about asking for stuff that we needed for patients, but having gone through this MAD round process, they really understand the issues that we encounter, why we need stuff, why certain things are important, even though they may seem small to them. And they have really enjoyed being part of this team. It also gives us an opportunity to talk to our own frontline staff and give them the encouragement that they need every day. When patients are saying positive things about them and we as leaders go and speak to them about it, it really empowers them and wants them to do more for their patients. So the whole MAD round experience has been very positive.
So the primary focus was to improve the patient experience, but it's had a lot of beneficial byproducts. The collaboration between individuals that may not otherwise communicate on a regular basis has certainly improved, and people who may not have had direct patient care experience, get to really interact with patients and understand the importance of what we're trying to accomplish. And that's also been enhanced by the iListen program, which Sabiha made reference to earlier.
So I think the work that you're doing is really terrific, and Sabiha, I think the role that you've described really fits with the Imaging 3.0 concept of placing radiologists in pivotal positions in both clinical and administrative care teams. I think Imaging 3.0 really asks radiologists to lead transformation in their organizations, and I can see how you have done this with a lot of the innovative things that you've introduced to your hospitals. I was wondering if the two of you could share some of the other innovative things that you're doing. Bruce, I think you mentioned something about a Fitbit challenge.
Oh, yeah. So we're about to roll that out on October 1st. This is an outgrowth. And in order to be an effective leader, oftentimes all you have to do is listen to people. So this is an outgrowth of an initiative that came from some of the folks who work in our emergency department, the administrator for the emergency department, and about 30 of his colleagues, some in the emergency department, some from various other aspects of the organization, decided that they wanted to make some minor improvements in the emergency department. They'd have like a little fundraising challenge. So they all have Fitbits, and their challenge was to see who could have the most steps. And since I guess we have a lot of competitive people in our organization, they ended up collecting, I think in 1 month, they collected maybe like around 11 million steps. It was 1 or 2 months. It was absolutely incredible amount of steps. And they were telling me about this, and I said, wow, this is such a great idea. Why don't we roll it out for the whole organization as part of a health promotion for our staff to live a more active lifestyle. So on October 1st, we're going to be acquiring a software app from Fitbit that will track a variety of things, including the number of steps. We were able to work out a special arrangement with Fitbit, and the hospital will also be subsidizing some of the cost of the devices, and we're hoping that we get widespread involvement by our staff because we think that it will help them improve their lifestyles and keep them healthy. And I said earlier, they're our greatest asset.
So I think I would like to talk about that a little bit more, and we'll move on to the next slide. You've mentioned some important aspects of relationships with not just your patients, but with your employees: trust, respect, and security. I'd like to ask you and Sabiha to talk a little bit more about the importance of these things in your organization.
So if I can start, and certainly after that defer to Sabiha. So trust is especially important in a relationship. You really have to trust the people that you work with. Respect them as professionals, knowledgeable, experienced people. And security has to be within yourself. You have to be secure in yourself, that you don't have to do everything yourself. You know, it's great to have smart people around you. Oftentimes, smarter people, much smarter people in the room than myself, and all I have to do is defer to them. But if you're going to really accomplish everything that you have the potential to accomplish, you need to develop these relationships as part of this team effort.
And really, that trust piece I can speak to. So when they appointed me the chair of Radiology Department was very early on in my career, so I really had to work hard. But I knew that once I developed that trust with them, then my job would become easier. So today, they have seen me work in this department for 20 years. they know that if I need something, they trust me enough to know that it must be important. So I don't have to go there, have a business plan, make explanations for things I need. If I need it, I go there, they have the money, they will approve it. They don't have the money, I understand they don't have the money. So that trust piece has made my job as a chairperson and now as a chief medical officer much easier, because we know what the physicians need, they understand our needs, and we understand where the administration is coming from.
So I think we'll ask people to start entering questions into the chat box right now. And while we're waiting for some questions to come in, I'd like to ask you just a couple of final questions. Bruce, I know it's incumbent, you've mentioned many times, on leaders to develop other leaders. Could you talk a little bit about how you motivate people to achieve their fullest potential? I think Sabiha is a good example of how you've done that.
Well, just give people the opportunity to do what they want to do, and step aside and make room for them to do it. So one of the things that Sabiha mentioned earlier with regard to our I Listen program, which was developed by our Vice Chairman of Family Medicine, I've participated in those I Listen sessions, and hopefully I've listened effectively to her and to the residents in those sessions. And it's always interesting for me to hear her talk to the residents and say, if you're mission-driven, then this is the right place for you. And if you're not mission-driven, then maybe you ought to consider someplace else. One of the things that has been extraordinarily motivational and helpful in allowing people to achieve their fullest potential is these things that fall under that category of being mission-driven, which may not be just about the productivity of their job or other tasks that they are responsible for on a daily basis, but allowing them to get involved in things beyond what they would normally be assigned to.
That's terrific. I think we'll move on to some of the questions that have popped up in the chat box. The first question is, when there are gaps in the patient experience identified during their radiological procedures, how are they generally addressed, and if necessary, standardized throughout the system? I think this is probably a question for you, Sabiha.
Yes. So this program that we have right at my hospital, every morning at 7 a.m. I get the report from the previous 24 hours, and many of my managerial staff get the reports. And my entire team knows that I look at those reports seriously every morning. So if we do find a patient issue, then the expectation from my staff is that they would reach out to the patients within 24 to 48 hours to do service recovery. We also look at trends to see if there's a trend that is causing any issues. So, for example, at one of my hospitals, we found when patients complained, they mostly complained about wait times in ultrasound. So we designed our next PI project for that month was reducing the wait times for our ultrasound. And when everybody put their eyes on the process, we were able to significantly decrease that wait time. So yes, we do look at the issues and we do follow up on them.
A question that came up, Bruce, when you were discussing the Fitbit challenge was there a budget for that initiative, or how did you fit that into other initiatives that you have going on?
So it will take a small financial commitment, but and this was not the motivation, but we expect the return on that investment to be significant. We are self-insured for our non-union employees' health insurance. And we fully suspect that by keeping them as well as our unionized employees healthy, we'll be able to reduce the cost of providing health benefits. But really, it's a very modest amount of money that we have committed for the software app and helping offset the cost of the Fitbit devices.
Terrific. Another question, have you performed ACR Imaging 3.0 utilization projects designed to reduce inappropriate utilization of imaging exams?
Yes, Amy, we have. The first thing that we, as I said, we utilize the imaging value chain to look at our processes. So the first one was how do we look at appropriateness of imaging. So in 2015, we had the clinical decision support, which is ACR Select, implemented in our both our hospitals on the inpatient side. We have, after having the ACR Select implemented, we also started a consult service in radiology. So when the physicians are going through ACR Select, and if they still have questions, they still have the option of calling the consult service and discussing with the radiologist what the most appropriate test is. And when I look at those reports, over time we have made significant improvement in reducing inappropriate tests. For example, in the first year, we went to up to 65%. If people who are aware of the appropriateness criteria, 65% of our studies were in the 7 to 9 range, about 25% or 30% were in the 4 to 7 range, and those really low appropriateness was very little. But what was also interesting is there was like a 12% cancellation rate, because with appropriateness criteria, they probably realized that that study was not needed. So that ACR Select and having the consult service has really helped us.
A question for Bruce. Getting buy-in for change from others can sometimes be difficult. Where have you found the most difficulty in getting buy-in for these programs that you put in place? Other radiologists at your hospitals, administrators, other healthcare staff like the radiology techs or nursing staff on the floors? And what's the best way to alleviate this impediment?
So I'll be happy to take a shot at it, and then I would encourage Sabiha to chime in. So we'll stay with the MAD rounds. For example, there were some naysayers in the beginning that didn't feel that we would be able to make changes. They were concerned that there'd be some financial limitations because some of the things that we needed were to acquire, say, maybe new equipment or furnishings or whatever, and there was not as much buy-in right off the bat as we would have hoped. And what was very interesting is as people started to make the rounds and started to engage with patients, the difference that they were making in the patient stay reinforced their commitment to want to continue the rounds, maybe modify the approach as Sabiha described. We went from having 3 members on the team to having individuals go out by themselves. You always have to be willing to change and be willing to listen to the people. We started to see some real positive changes in terms of the patient experience. We all struggle with things like HCAHPS and that kind of stuff. And so even analytically, we've started to see quantifiable improvements, which encourages us that we're on the right path.
And really what we have, the strategy that we are using here in our hospital now is really getting the front-end staff involved in everything. So we are not just, and then taking their input and improving our processes. For example, just this morning we were talking with our Joint Commission, because we're going through Joint Commission, we were talking about our sepsis protocol. When we were putting our sepsis protocol in, we have residents, we have nurses, we have doctors involved in that, so that when we are sitting to discuss how will we make improvements, and if a resident tells us if you do this, this, and this, you will have better buy-in from residents, we listen to them and we put those measures in place for them. So you have to have the buy-in from all your staff to be able to do these things.
I'll give you another example with regard to the iListen program. So again, with the person who runs the program and I met with many of the residents in the hospital, and in internal medicine, they wanted to change the way that they were assigned to have it be a geographic system. We said, well, why don't you come up with the system? They did. It took them 2 weeks. It was presented at one of our leadership meetings where all the clinical chairmen and administrative leaders gather. The residents did the presentation. It made perfect sense. And within 2 weeks of that, we changed the model. So by really listening to people and allowing them to be part of the change process, it reinforces that bringing their ideas forward will get consideration, and that builds upon itself.
This is a question for Sabiha. Sabiha, can you describe your role in the Transforming Clinical Practice Initiative and specifically the RScan project underneath of that?
Sure. For those people on the call, Transforming Clinical Practice Initiative is an initiative that CMS got a big grant for $685 million to help transform 140,000 practices throughout the country in a 4-year period so that these practices become then move into the value-based payment system. So this project started in December of 2015. For this project, they had 29 practice transformation networks, and they also had support and alliance networks which would help these transformation networks to move the practices along this path. And American College of Radiology is one of those support and align networks. So I guess at that time, the DCPI people had reached out to ACR for them to suggest a practice that they could use as a model for how quality work is provided within patient-focused quality work is provided in radiology. I guess they could have picked up any of the bigger center practices, but to make it more real for people, they chose a safety net hospital, so they chose my department and recommended my name. So I'm one of the national faculty leaders for the TCPI program, and I also work closely with ACR as a member of their team to promote the RScan program. RScan is a project that ACR got funded for through this project, and the purpose of this scan was to make sure that we are reducing unnecessary testing. So ACR picked 10 to 12 choose wisely indications that they created a performance improvement project around, and the the ordering physicians and the radiologists can work together on these indications and help improve and reduce unnecessary testing. For example, low back pain or imaging for pulmonary embolism, unnecessary follow-up for adnexal cysts. So I've been working with the TCPI program since 2015, and I also work with our RScan people so we can recruit radiologists and clinicians to be part of this program and show them how they can improve processes within their departments and reduce unnecessary testing.
Thank you, Sabiha. I don't see any additional questions in the chat box, so I would like to take this opportunity to thank the AHA for giving us this platform for this discussion and to share all of the work that Bruce and Sabiha are doing at their institution. I will, at this point, turn it over to Elisa.
Thanks so much, Amy. And I want to just add my thanks to Bruce and Sabiha and Amy for such a great webinar. Love to feature all of the great things our members are doing, and that was just a really great story. So to our participants, thank you for participating in today's webinar. Just so you know, you will be able to find a recording of this session and a copy of the slides on our website, which is ahaphysicianforum, all one word, .org, and those should be posted by early next week. You also will be receiving an evaluation in a follow-up email, so we'd love to hear from you both what you thought of this session and then other sessions you'd be interested in hearing. Again, thank you so much for joining us, and we're adjourned.
Thank you, ladies and gentlemen. This concludes today's conference. You may now disconnect your lines. Speakers, please remain on the line.